chronic aspergillosis in research limited settings like in many countries in Asia. A chronic pulmonary aspergillosis is a long-term aspergillosis. It is different with infection which happens in the ICU, which is acute one, but this must be caused also by the same fungus, but different clinical pathway. Mostly it caused by Aspergillus fumigatus, but another Aspergillus such as Aspergillus niger and Aspergillus flavus, depends on the geography, can also cause the disease. This disease is an uncurable disease. It worsening with time, and if we couldn't recognize the patient, untreated one, it develops fibrosis, which worsening, and we have no choice that the patient will die because of this disease. So this is the work of my colleague David Denning from Manchester University, which is very famous for his work on the chronic aspergillosis. This is the type. The first type is simple aspergilloma. When I was a student, my teacher told me you can disobey this. It doesn't matter if the patient doesn't suffering from hemoptysis, but many patients suffer from that. And the second one is the chronic pulmonary aspergillosis with many cavities and a thick wall cavities. And then the third part is the fibrosis type. And the next is the nodule, which usually happens in the early stage of the disease. And the last type is we can say semi-invasive, which is also then can goes to chronic aspergillosis. Again, from my colleague Denning's work, we can see in his website of Life, CPA epidemiology affects 3 million people worldwide. But what I want to tell you is that we are in Asia have so many tuberculosis cases, which is the underlying condition for this disease. Because most of the patients suffering from chronic aspergillosis have had tuberculosis before. The underlying condition for chronic pulmonary aspergillosis is damage in the lung caused by other diseases, which becomes a fertile places for the growth of aspergillosis and of aspergillus. Aspergillus in that place is not only growing, but it's also invade tissue, doing invasion, and aspergillus has proteolytic enzyme, toxins, and other metabolites that make things worse. That's the reason why the patient with chronic aspergillosis is become more ill by the time. This is the underlying condition of chronic pulmonary aspergillosis. Use of alcohol, tobacco abuse, diabetes, and it causes deterioration in local or systemic defense against infection. And bronchopulmonary aspergillosis, bronchopulmonary diseases like TB, and prolonged use of corticosteroid. But I think in Asia, the most common cause is tuberculosis. We know that 3 countries in Asia, India, China, and Indonesia, is ranked first and second in the number of tuberculosis cases, especially pulmonary aspergillosis. That's we have to be very careful in the patient with tuberculosis or post-TB patient. This table done by Izumikawa from Japan tell us what is the underlying condition he find out in his patient. Tuberculosis is number 1, then bronchiectasis, prior pneumonia, pneumothorax, COPD also related with using of smoking, and I think many people are smoking, even the young one, and also surgery, and systemic conditions such as diabetes, steroid usage, and other systemic conditions, and of course malnutrition. What is the sign and symptoms of the disease? Mostly, the sign and symptoms, we could not differ it from another pulmonary infection, a chronic one. So we couldn't rely only on the clinical sign and symptom. We need the help of people like Professor Arya, who works in the laboratory, Dr. Virus, and also we need the help of the people who works in the radiology. We need imaging. We can see cavity, we can see nodule in the early stage, and for mycology investigation, is culture is needed, but we have to be very, very careful in interpretation of the result of the culture, because this fungus is also saprophyte in the human airway. And precipitin test, the serology, testing the antibody, is the actually a cornerstone, but not many laboratory can do this. You can see here work from two places, from Iran and from Japan. We can see the patient that's mostly are male, so I'm happy to be female because I'm not prone for this. And also we can see the pulmonary clinical sign like cough, sputum, and hemoptysis and dyspnea. And duration usually 3 months after we are tested the patient. We can see later on in the case report. I can summarize here that symptoms, pulmonary system usually lasting more than 3 months, and usually are weight loss because the problem with respiratory system, fatigue, cough, and hemoptysis, and breathlessness. And chest x-rays showing cavities are more than one, and nodules usually in the early stage of the disease. But the key diagnostic is precipitin test to detect antibody against Aspergillus in serum or in other body fluid, such as from the respiratory aspirate. And in the laboratory, we can find the branch hyphae specific for Aspergillus. Culture positive is low, sensitivity is only 25%. PCR more sensitive, but mostly remain negative. And again, I remind you that if we can find or we can isolate or even with PCR detect the fungus, we have to be careful because the nature of saprophyte of this fungus. This fungus, I forgot the name of the researcher, but that study tell us that in 1 microliter of air, we can find 5 spores that we easily inhale to our respiratory system. So even our healthy immunocompetent person we can isolate Aspergillus from his upper respiratory tract. So we have to be very careful in the interpretation of this culture result. Biopsy, biopsy is we can find the fungus there, and for the biopsy we can ask the help of the histopathology, but we can also do the direct examination as done by Dr. Arya previously for mucor. We can find the branch hyphae and we can do the culture. But sometimes the fungus is already dead, that doesn't grow in culture. And how about the treatment of this disease? Unfortunately, until this time, no standardized treatment for the disease, even though David told me that he suggests to give itraconazole for treatment of this disease, but still we don't have the codified treatment yet. If there is, so the treatment is mostly based on the symptoms of the patient. If your patient suffering from hemoptysis, then what you do is surgery or embolization. But sometimes surgery is difficult to be conducted because the patient condition doesn't allow us to do that. And antifungal, we can choose between itraconazole or voriconazole, but because it is a long-term disease, long-term treatment, voriconazole, it's difficult to be the drug of choice because it's expensive, and it is also reserved for the acute infection. And how about us, the resource limited setting? Am I correct that it is us, the resource limited settings? Because for Indonesia, which consists of 17,000 islands, the discrepancy between the big cities and the remote places is quite big. The laboratory mycology laboratory is not available in every part of Indonesia, only in the big cities. So what we can do is diagnosis based on the clinical presentation. Please ask the patient about the history of pulmonary tuberculosis, or does he has or she has infection of TB, then or post-TB infection and other underlying condition. That's important for us to establish the diagnosis. And again, the diagnosis, that's where the MMT and I told Robert yesterday can work, because we can provide the person who can work in the laboratory to help us to the diagnosis. Because for this CPA, the laboratory diagnosis is quite important. We can do the culture, we can do the mycology test there, but I don't think about the precipitin test. And if you have the positive result of culture, then you have considered the nature of Aspergillus as the saprophyte in the human body. And how about treatment? Treatment, I think itraconazole is easier to provide in a resource limited setting. But the problem with itraconazole is it is widely used. This is a very potent antifungals. It works for yeast, it works for molds, but it used for systemic infection and also superficial infection, so it is widely used. And what my concern is that emergence of resistant strain, because we start to see resistant strain, and I think in India it's already reported as a problem. I don't know it at your place, but in Indonesia, this azole derivative is also used for agriculture purpose, and the use of agriculture purpose as the side effect is also killing the Aspergillus, but they are then emerge the resistant strain. So this is the weakness of using itraconazole, even though this is a very good drug, but still we have the problem with the emergence of resistant strain. I think I can make a kind of algorithm for a patient with CPA, how to diagnose. If we see here patient with underlying disease condition and infection, usually doctors will first thing gives the antibiotics. And if the patient gives a positive response, then we can continue with antibiotics. But if it is no response, then just explore more clinical information, do the imaging, and ask the laboratory help if it is available. Otherwise, you can do from the clinical information or the conventional chest X-ray. And if all the clinical information and the result of antibiotic treatment is suitable with CPA, then you can start with itraconazole. It is easier to find. And how about the prognosis of the patient? CPA is often diagnosed late, leads to improper treatment, and it becomes worsening. Progresses toward worsening in line with pulmonary tissue destruction, and mortality rate is circa 15 to 30% in the first 6 months after diagnosis. And what we can do is only the hard progressiveness of the disease. We couldn't save, I'm sorry, his life. And now I want to show you a case report, which is a collaboration between my laboratory and Dr. Dewiana from the RP hospital. She sent us a 60-year-old lady with recurrent hemoptysis, looked very ill, cachectic, and lost weight during the last 10 years. In 1998, she was diagnosed as a pulmonary TB. And in 2003, again, she was diagnosed as pulmonary TB, relapse, but in 2007, it started bloodstream for the first time, but the acid-phase bacilli is negative. 1 week treatment with antibiotic, the patient feel better, but the diagnosis is residual TB. On February 2010, again he suffered of profuse hemoptysis and admitted to hospital. The result of CT scan, the right lung is a rough bronchopulmonary vascular pattern, bronchiectasis, fibrosis, cavities on top. But again, acid-fast bacilli is negative. And pulmonary lesion, she is diagnosed as the residual TB. They consider it as the result of the previous TB infection. On March 12-11, CXR was changed. Diagnosis is infected pulmonary bronchiectasis, previous TB, and recurrent hemoptysis. And at this time, the treatment, antibiotic treatment, has no response, and she started to send to our laboratory. But I want to show you this because she is already suffering from TB, and her house is clean and in a good condition. She is a very tidy lady. But his office, at that time, he is moving to her office was renovated, and they are moved to a damp old building, and after that, she started to have hemoptysis 3 and 4 months later. So I think the process of the damage of her lung is continue, but the infection of Aspergillus is start at that time. And she was sent to our laboratory in 2011. We did the sputum investigation for 3 days, and we couldn't isolate Aspergillus. Instead, we isolate Candida albicans, but Aspergillus antibody is positive. Based on that, we give them the treatment for chronic Aspergillosis. On July again, we test the patient after treatment, and the Aspergillus niger we can isolate it, but antibody against Aspergillus is still positive. Then in August, again she suffered of hemoptysis, and we isolate Aspergillus fumigatus, which is susceptible to itraconazole and voriconazole, but resistant to SDD to amphotericin B. And we also identified PCP at the time, but we don't give treatment because treatment was itraconazole enough for her. This is the result of the imaging. You can see the CXR at 2010 and also 2011 show the destroyed lung. This is the CT scan. It's in line with CXR. And based on this chest CT scan and previous lab investigation, the diagnosis by the clinician is chronic cavitary pulmonary aspergillosis, post-TB, destroyed right lung with all that type of destruction. And treatment started with itraconazole, but antibody against Aspergillus still positive. And again, we can isolate the Aspergillus niger, and also we still detect antibody against Aspergillus, and itraconazole was given. And this is the last slide, I think. The diagnosis of the clinician based on the chest CT scan and laboratory is right destroyed lung and multiple bullae, and the treatment is itraconazole 200 milligram per day. She feels better, I don't know her condition now, but at that time the condition is better. So what we can do for this patient is only halt the progress of the disease. We couldn't cure it because this is uncurable disease. And at the end, I want to say thank you to my student, which is now my junior, Anna Rosialiani, pulmonology, and medical mycologist, and Dr. Dewi Kusmana and Dr. Fajar from Army Hospital. Thank you very much.